Pneumothorax causes, signs, and treatment. 1. Causes of pneumothorax. Pneumothorax is divided into spontaneous, primary, secondary, and due to trauma or procedure. Specific causes include primary spontaneous pneumothorax. Occurs in healthy people without underlying lung disease, often in young men, 20 to 40 years old, especially tall, thin people. Causes: rupture of abnormal air bubbles or cysts on the lung surface, usually at the apex of the lung, due to sudden pressure changes, scuba diving, flying. Risk factors: smoking, genetics, rare. Secondary spontaneous pneumothorax, related to underlying lung disease, including chronic obstructive pulmonary disease, COPD. Lung damage increases the risk of alveolar rupture, the most common cause. Pulmonary tuberculosis accounts for 40% of cases in Vietnam due to the tuberculous lesion rupturing into the pleural cavity. Pneumonia, lung abscess, lung cancer, pulmonary fibrosis, severe bronchial asthma, increased pressure or lung damage. Autoimmune diseases, rheumatoid arthritis, scleroderma. Bronchiectasis, cystic fibrosis, causes lung structure to weaken. Traumatic pneumothorax. Chest trauma, rib fracture, stab wound, traffic accident, or blunt object causing lung puncture. Medical procedures: pleural puncture, lung biopsy, central venous catheter placement, or bronchoscopy. Mechanical ventilation-induced pneumothorax. Positive pressure ventilation, as in emergency resuscitation, increases lung pressure, causing alveolar rupture, leading to tension pneumothorax, dangerous. Risk factors: smoking, increases the risk of lung damage. Gender: men are more susceptible than women. Pressure changes, deep diving, flying. Family history: some cases are genetic. 2. Signs and symptoms. Symptoms of pneumothorax depend on the degree of collapse and the cause. Typical signs include respiratory symptoms: sudden chest pain, sharp, severe pain on one side of the chest, increased when breathing deeply or coughing, can spread to the shoulder or between the shoulder blades. Difficulty breathing. The level increases with the amount of air leak, from mild difficulty breathing to rapid, shallow breathing. Dry cough usually occurs when changing position, increasing chest pain. Systemic symptoms due to lack of oxygen. Pale purple skin, especially on the lips, fingertips. Sweating, fatigue. Pale, panicky. Rapid pulse, low blood pressure. Signs of shock, especially in tension pneumothorax. Special signs. 3. Reduction syndrome on physical examination. Reduced chest mobility. The side with pneumothorax moves less when breathing. Percussion resonance. Sound is more resonant than normal due to air in the pleural cavity. Decreased fremitus. Vibratory sound is weak or absent when palpated. Tension pneumothorax with valve. Severe dyspnea. Rapid cyanosis. Low blood pressure, heart deviation to the opposite side due to mediastinal compression. Critical condition, can die within minutes if not treated. Mild cases. Some cases of small pneumothorax, less than 10%, have vague symptoms, mild chest pain, fatigue, easy to miss. 3. Diagnosis. Diagnosis of pneumothorax is based on symptoms, clinical examination, and paraclinical tests. Clinical examination: auscultation of the lungs, reduced or absent alveolar murmur, detection of 3 reduction syndrome. Chest X-ray. Typical image is a separated pleural border. The lung area has lost blood vessels. Chest CT scan. Accurately determine the extent of lung collapse, find air cysts or underlying pathology, used when X-ray is unclear. Pleural ultrasound. Detect air in the pleural cavity Support aspiration. Arterial blood gas. Assess low oxygen or high CO2 levels. Respiratory failure. Electrocardiogram, ECG. Rule out heart disease if there are similar symptoms. Chest pain, shortness of breath. 4. Treatment. Treatment of pneumothorax depends on the extent, cause, and patient's condition. The goal is to remove air in the pleural cavity, help the lung re-expand, and prevent recurrence. Methods include monitoring, mild pneumothorax, less than 10 to 15%. Application, primary spontaneous pneumothorax, asymptomatic or mildly symptomatic with minimal lung collapse. How to do it? Rest, avoid exertion. Supplemental oxygen via the nose if needed. Take a follow-up X-ray after 4 to 6 hours to ensure spontaneous resorption of the gas, usually within a few days. Note: do not fly or scuba dive for 6 weeks after recovery. Aspiration, moderate pneumothorax. Application, symptomatic spontaneous pneumothorax or lung collapse, 15%. How to do it? Use a small needle or catheter, 7 to 9 French, to puncture the second intercostal space, mid-clavicular line, or 4 to the 5th intercostal space, anterior axillary line. Aspirate the gas with a syringe or connect to a one-way valve, Heimlich valve. Effectiveness. Lungs can re-expand after 2 to 4 liters of air suction. If ineffective, switch to drainage. Place a chest tube, severe or secondary pneumothorax. Application, large pneumothorax, tension pneumothorax, or pneumothorax due to trauma/mechanical ventilation. How to perform. Place a chest tube, larger in size, into the pleural cavity, connected to a continuous suction system, negative pressure. Ensure sterility, tightness, and one-way suction to avoid air reflux. Patients usually have to be hospitalized for 2 to 7 days. Supportive medications. Pain relievers, paracetamol, ibuprofen. Cough suppressants. Paxlovidine, if severe coughing causes pain. Antibiotics. Cephalosporin, if there is a secondary infection, pneumonia, abscess. Oxygen inhalation, if respiratory failure. Surgery, recurrent or unresponsive pneumothorax. Application, recurrent pneumothorax, 50% risk of recurrence, large air cysts or failed drainage. Methods. Thoracoscopy, VATS. Find and suture the air cyst, remove the damaged lung. Pleurodesis. Inject chemicals, talc, doxycycline, into the pleural cavity to adhere the 2 pleural layers, preventing air from leaking back. Pleurectomy. Rare, used when other methods fail. Effectiveness. Reduce the risk of recurrence to less than 5%. Treat the underlying cause. Pulmonary tuberculosis. Use anti-tuberculosis drugs, rifampicin, isoniazid, ethambutol, for 6 to 9 months. COPD, bronchial asthma. Optimize treatment, bronchodilators, corticosteroids. Lung cancer, chemotherapy, radiotherapy, or surgery depending on the stage. Emergency treatment for tension pneumothorax. Signs: severe shortness of breath, cyanosis, hypotension, and shunting. Immediate treatment. Insert a large needle, 14 to 16 G, into the second intercostal space, mid-clavicular line, to release air quickly. Then place a drainage tube and transfer to the ICU. Note: must be performed by a specialist. Avoid delay because of high risk of death. 5. Complications. If not treated promptly, pneumothorax can cause respiratory failure due to lack of oxygen, CO2 accumulation. Re-expansion pulmonary edema, Occurs when the lung expands too quickly after a long period of deflation, 72 hours. Cardiac tamponade, pressure pneumothorax pushes the mediastinum, reducing blood return to the heart. Infection, pneumonia, pleural empyema due to non-sterile procedures. Recurrence, risk of 50% if not treated thoroughly, especially in patients with COPD, tuberculosis. Stroke, heart failure, due to prolonged lack of oxygen or air embolism. 6. Prevention and follow-up after treatment. Prevention. Quit smoking, avoid cigarette smoke. Avoid sudden pressure changes, deep diving flying for 6 weeks after recovery. Get regular health checkups, especially if you have underlying lung disease, COPD, tuberculosis, asthma. Get a tuberculosis vaccine, BCG, for children, and a pneumococcal and influenza vaccine for high-risk adults. Follow-up. Re-examination after 1 to 2 weeks, take a X-ray. Follow-up with treatment for underlying disease, tuberculosis, COPD. Report to your doctor immediately if chest pain or shortness of breath recurs. 7. Important notes. Timely emergency care. If you have sudden chest pain, difficulty breathing, or cyanosis, call 115 or go to the hospital immediately. Bach Mai Hospital, Vinmec, Tam An, or the nearest medical facility. Do not self-treat. Pneumothorax is a medical emergency and cannot be treated at home with folk remedies or breathing exercises. Risk of recurrence. People who have had pneumothorax need long-term monitoring, especially in the first 2 years. Not contagious. Pneumothorax is not transmitted through the respiratory tract, except in cases of pulmonary tuberculosis. Thank you for watching the video. Wish you and your family good health and happiness.